afternoon and welcome to the second installment of our Human Resources for Health Spotlight series. And the title of today's webinar is How do we collaborate with other sectors and ministries to improve health, workforce education, employment and retention? That's a long title. It's complex because it's a little bit complex, the topic. And it's so complex because it's about reaching out to other sectors which have at face value not so much to do with health systems, but in fact, we need education to produce the health workforce we want. We need finance to invest into a health workforce. We need employment to create the opportunities and the context in which people can really work and be productive. And working with different sectors might be quite difficult because they have different objectives, which are all perfectly correct. Like, for example, academic excellence or vocational professionalism. They insist on efficiency. They need to check opportunity costs. They also are very focused on processes, all perfectly legitimate objectives, but not necessarily aligned with our health system demands, with what our health systems need and what the health systems reforms are actually looking for. So it's really about this sort of alignment between different sectors to increase the numbers, change the skill mix, introduce team-based care for patients. And to address this topic today, we've lined up an excellent panel of speakers. We have today as a keynote speaker, Margaret Caffrey from the Liverpool School of Tropical Medicine in the United Kingdom. Many of you know her. She's a renowned researcher into global health issues. So she knows health workforce issues around the world. And we have also secured two other excellent spotlight speakers who will fill us in on Georgia. It's Chris Goddard from the WHO Regional Office for Europe, a dear colleague of ours. And it's Ronald Bartenburg from the NIVEL Institute, the Netherlands Institute for Health and Services Research. And Ronald will talk about the Netherlands, of course. And the Netherlands is a very important example because it's a kind of poster child of intersectoral collaboration and health workforce forecasting and planning. And I think we will learn a lot, but also hear about worries about the future of this system. And last but not least, I'm so happy to announce that we have secured Jim Campbell. He's the director at the World Health Organization for Human Resources for Health. And Jim is joining us as a discussant. And I should also mention that this series on the health workforce is organized together with our colleagues from WHO headquarters. Just a couple of things on the housekeeping. First of all, please use the chat to put in questions, comments, or if you have a document which you want to share, please feel free about this. We will collect them and feed them to the panelists at the end of the meeting so that they can respond to it and that you get your pressing questions and issues considered and also hopefully answered. Second, we will record this session, and also in 2-3 days after the webinars, you will have this session lightly edited on our YouTube channel. I should have also mentioned that this is again supported by my colleague Erika, who is actually looking into the chat box, and Lucy, who is managing all the technology. So that's it for the introduction. And now it's the opportunity to give Margaret the floor. Margaret, the floor is all yours, please.
Thank you very much, Matthias. Thanks to the Observatory WHO for hosting this webinar and for supporting the development of this policy brief. Thanks also to the co-authors of this brief who are here with us today. While COVID-19 gave the world a new appreciation for the health and care workforce, it also highlighted some of the challenges countries have been grappling with for decades, including shortages and maldistribution, inadequate skills mix, and poor and unsafe working conditions. It also highlighted the need for health workforce governance to address these challenges. In managing the pandemic, countries worked across government sectors, including health, education, and finance, and with the private sector and the community, adopting intersectoral approaches for health workforce strengthening. We must take advantage of the learning and the evidence of good practice from this time going forward. This policy brief explores how intersectoral governance can enhance health and the care workforce, the planning and development of the workforce to ensure that education, employment, and retention of this workforce are considered holistically. Next slide, please. So as in the development of our policy brief, we used various methods. For example, we reviewed a range of literature and reports, mapped existing intersectoral governance mechanisms at global, regional, and national levels. We examined how they worked, the benefits and the challenges, and how they could be strengthened and leveraged to optimize the benefits on healthcare, workforce, education, employment, and retention. We also included some case studies from around the world, and these provide insights into intersectoral governance and collaboration in practice. Drawing on the evidence, the brief sets out key principles and practices that governments can adopt to support and strengthen intersectoral collaboration and action on health workforce planning and development. Next slide, please. Governance is vitally important to health and health workforce policy and implementation. It refers to how decisions are made and implemented, from the ability of policymakers to take evidence-based and relevant decisions to their ability to implement policies and create alignment between different actors. The evidence tells us that educating, employing, and retaining a sustainable health and care workforce requires effective cooperation and governance across multiple sectors at all levels of government and with other non-state actors. Yet, all too often, different sectors work in silos with little effective collaboration. For example, education policy and investment decisions may be taken by the education sector, but often delinked from the needs of the health sector. In many countries, evidence-based workforce planning to understand current and future supply needs is not undertaken, sometimes due to a lack of reliable data and or institutional capacity. Next slide, please. So some of the principles of governance and intersectoral governance that were relevant here. The literature has picked up on governance is a very complex and broad topic, but governance concepts and ideas in the literature are broadly grouped into these 5 key domains. These are also relevant for effective intersectoral governance, collaboration, and action. And they also highlight the need for transparency around decision makers and decisions, and the evidence that informs decision-making processes, as well as the co-benefits to other sectors. The health sector and Ministry of Health need to be accountable for their actions on the health workforce and be seen as trusted partners. Stakeholders both within and outside the health sector need to participate in a meaningful way, enhancing ownership and investment in strengthening, health workforce strengthening. Health workforce planning and development processes need to achieve results, and the integrity of the Ministry of Health will ensure that it's viewed as a credible partner. The health sector and the Ministry of Health also need to have the necessary capacity to develop, analyze, translate, and monitor and evaluate health and care workforce policies, which need to be aligned with resources. Next slide, please. So we looked then pulling the evidence together to inform and provide some guidance on practices that could be in place to support intersectoral collaboration and action. Next slide, please. Okay, and we come up with 5 key messages and key practices that can support intersectoral governance on the health and care workforce planning and development. And these include political leadership and sustained government commitment from the top to set the health workforce development agenda across the whole of government and whole of society. While health sector leadership is critical and central to this process, Higher level political support at ministerial or presidential levels is often necessary to ensure intersectoral coordination mechanisms work and achieve the intended results. There also needs to be sustained investment in relationships with other sectors and strategies to build this trust. We also have seen practice from the evidence practices around building on and expanding the scope of existing intersectoral mechanisms and ensuring that the Ministry of Health can mobilize global and regional mechanisms and investments to support intersectoral collaboration and action. Key to these intersectoral collaboration and the evidence is around reliable healthcare and workforce data and forecasting. And this is also needed for the Ministry to be taken seriously by other sectors. We also need to change the narrative, the investment narrative for the health and care sector, and spell out the co-benefits for other sectors of investing in the health and care workforce. Next slide, please. So as we looked at the evidence and we reviewed the documentation, we identified national level mechanisms as well as high-level intersectoral governance mechanisms, both at national, regional, and global levels. Some were directly related to the healthcare workforce, others that could be repurposed or expanded to function. National level mechanisms included HR technical working groups, committees, coalitions, and councils, including the health workforce observatories that are in place, and as well as HR departments within the Ministry of Health. These are often leading and coordinating an intersectoral response in the various countries. There were also high-level intersectoral governance mechanisms, such as cabinet and parliamentary groups, with representation from various sectors, including health, education, labour, finance, supporting and promoting intersectoral collaboration and action. However, intersectoral collaboration often fails because of a lack of financial resources. And we found evidence of joint budgeting and delegated financing, where financial resources were pooled to support collaboration. And these too could be a consideration for the health workforce. Next slide, please. Just one example of an all-party parliamentary committee. As we found in the evidence, these sort of committees can encourage more consensual approaches, enhance the potential influence of findings, and as well as create stability within the reform process, supporting the longevity of an issue as a political priority, even beyond a change in government. So from this example, the intersectoral governance promoted by the Oireachtas Committee on the Future of Healthcare enabled consensus on the future health and care system in Ireland and has led to sustained resourcing and implementation of the Sláinte Care initiative, including health workforce outcomes. However, the scope and capacity of existing intersectoral governance mechanisms to develop coherent, sustainable, and cost-efficient healthcare workforce interventions and to mobilize investments varies across contexts, including the level of health workforce literacy and understanding of the issue, as well as the political importance of the health and care workforce as an issue. Next slide, please. So the lessons of the pandemic suggest investing in and extending and strengthening the scope of existing intersectoral mechanisms and mobilizing interdepartmental groups and parliamentary committees would be beneficial for healthcare workforce strengthening. Using the evidence, the policy brief looked at how intersectoral mechanisms can be leveraged and strengthened to support the education, employment, and retention of the health and care workforce. Next slide, please. So we talked about this, we talked about the extending the scope and leverage of these mechanisms. So achieving the health workforce outcomes around education, around retention, and around employment all require robust intersectoral governance. The steps in the process are outlined here, which could involve, firstly, a recognition for the need for intersectoral collaboration. Then identifying the government structures that could be capitalized on, particularly those that consider the health workforce as of political importance. Within the group, it's important to develop shared goals, targets, and indicators. Coordination agreements or legal mandates could also help reduce fragmentation and duplication of actions, as well as enhance the sustainability of these mechanisms. Robust leadership, monitoring, and evaluation are also key to the process. Next slide, please. So we've talked about stakeholders, and this is just presenting some of the key stakeholders. As you can see, multiple stakeholders occupy the policy space for the health and care workforce. The evidence highlights the importance of inclusive and participatory intersectoral mechanisms to engage and coordinate stakeholders, to foster a shared understanding and ensure that interests and priorities of all these stakeholders are aligned, and to make planning and delivery mechanisms compatible across all sectors. Beyond the national level, we also need to look at these type of mechanisms that ensure stakeholder participation at different levels of government, at local governments and local authorities, communities and health workers, to ensure that there are skilled and competent health and care workers available, accessible, and retained to provide quality primary healthcare services. The importance of meaningful stakeholder participation was highlighted at multiple speakers at the recent HRH forum, with one remarking on how health workforce development is a team sport, and we need to have employers at the table early and often to ensure graduates are ready for work. Next slide, please. So securing and sustaining political will is critical for intersectoral collaboration. From the pandemic, there was an increased understanding and literacy around health workforce challenges. This could be an important catalyst to generate and sustain political will. Whole of government approaches and leveraging the tangible co-benefits of intersectoral cooperation and a well-performing health workforce for other sectors could be done through the use of tools such as health in all policies and health for all policies. Political and legal mandates would help to sustain intersectoral governance mechanisms and also legitimize the health sector's role in leading and coordinating an intersectoral agenda. Strong governance and strategic leadership skills will enable the Ministry of Health to coordinate an effective intersectoral response and to leverage the education, the labour, the economic development infrastructure to advance the health workforce agenda. Next slide, please. So one of the key areas is ensuring we have data, that the data is reliable and timely, and there is evidence for strategic health workforce planning, development, and investment, and the ability of the Ministry of Health to be able to communicate these to other sectors, which will strengthen the alignment of, for example, educational outputs with health workforce demands, and will also contribute to improved distribution, availability, and quality. We're seeing improvements in the quality of data through the health workforce accounts, through the observatories. More countries are using labour market analysis to generate research evidence. Thank you. One more slide, and two more slides, and I'll finish up. Next slide, please. Just to provide the words of Dr. Tedros at the recent forum around acting together, the emphasis on political leadership and coordination across the sectors, as well as engaging with non-state actors. And we'll skip to the last slide. Next one, please. Yes, just to say thank you. And also just to point out, another great read on health workforce governance is included here in the link on this paper. Thank you very much indeed for your time. Sorry, I overran a little. I see Matthias ready to jump in.
We thank you. That was really great, quite comprehensive and still concise. And I think it really very well represented the policy brief and also what we were discussing at the 5th Global Forum on human resources for health, which was organized by Jim and colleagues. And if I come back to some of the key messages you actually brought across, one was political leadership. And I think we have seen this last week, learnings for working conditions. Political leadership is really very necessary also in intersectorality. You've been talking about the investment in relationships. So it's not, a one-off thing, or we just need money for this particular project. There need to be a long-term relationship, building trust. And the other one was actually intersectoral governance mechanism. And you were showing the example of Ireland with frontier care. I think that's a very important example, that you have some sort of cross-parliamentary consensus. And of course, the reliable data, you were focusing on it again. When we were testing some of the messages coming from the policy brief you wrote, Margaret, we were discussing them with colleagues from the other regional offices. And this was something that really, really resonated very much. I think we all know that the health sector needs to do its homework, and has the data and the analysis and the policies ready for this sort of intersectoral discussion. And last but not least, the investment narrative. And that is something we are trying to get right at the moment, because we all know COVID-19, well, it's not quite over yet, but the investment in health for COVID-19 reasons will no longer be as strong as it used to be. And some countries are already seeing the shrinking of the fiscal space, and we need to have a good narrative, a good argument why it's worthwhile still investing in the health. So thank you so much, Margaret. I think it's a great overview on this topic. And it's now my great pleasure to ask Ronald Bartenburg to come on board and give us a little bit of an insight and a case study actually on the Netherlands. Ronald, the floor is all yours.
It's a pleasure for me to talk about my own country, the Netherlands, and I'm going to, present it as a case study, but from a specific perspective as being an inhabitant of the Netherlands for all my life also. So I'm positive, but also I'm critical. And just as a first sentence, the Netherlands is a relatively small country, as you probably know, but also a densely populated country. And if we look at the statistics, about 1 out of 6 of the active labor population is currently working in or for the healthcare sector. And if the demand for healthcare in the Netherlands will continue, this ratio should be 1 in 4 in about 10 years. So in short, this is the main challenge for our country. And because it is expected that we cannot realize this ratio in the near future, we simply reach limits to growth. Inflow and training for most health occupations is stabilizing or declining, while on the other hand, outflow from the health workforce is growing, not only due to retirement and aging of the workforce, but also due to an increasing dropout caused by a negative spiral at the shop floor of healthcare facilities. In all healthcare sectors, we see an increased workload due to shortages, causing burnout stress, which further increases the workload, and not to mention the negative effects of administrative burden and skill mismatches. And this means that the health workforce planning system we have in place in the Netherlands for about 20 years also reaches its limits. For 20 years, controlling the training inflow in medical school and specialty training has successfully prevented the so-called pork cycle on the labor market for physicians. This is also shortly described in the policy brief. But still, the health workforce planning system works as a demand-based forecasting model. And it has been extended and improved by better data, better modeling techniques, better software, and most importantly, by the successful involvement of stakeholders. Professional associations, but also healthcare insurers and training institutes are involved in both the input, scenarios, and output of the Dutch health workforce planning model. As the planning cycle is 3 years for most health occupations, these stakeholder organizations have become part of expert panels and are aware that they are co-responsible for the policy decisions that result from the planning system. And these policy decisions has mainly been so far based on adjustment of training inflow to close the current and future gaps between demand and supply on the labor markets for physicians and their different specialties. Increase training inflow to avoid undersupply, decrease training inflow to avoid oversupply, simply put. But here, the limits to growth are now challenging our health workforce system and policy. We need to change the system to a mix of policy instruments to be able to control labor markets and to secure a sustainable workforce. Next to training inflow, the model and stakeholders need to support recruitment and retention policies as well, to avoid early inflow and dropout, to improve return on training, but also to improve skill mix innovation, flexibility, increase of delegation of administrative tasks to digital solutions and support staff. And also the potential of increasing the part-time factor that is exceptionally high in the Dutch health workforce. And for this, the current health workforce model will have a new role, not only the normative role in terms of advising how many doctors to train, more or less, but also the role to project what-if analysis, to explore the potential effects of the different policy measures I just mentioned. This is important, as we know that policy development can be very different from policy implementation. And hence, planning models can help to shed light on the feasibility of different labor market policy options. So finally, this all implies that an intersectoral approach is more important than ever to connect to the theme of this workshop and to echo the important messages that Margaret just presented. If we aim for better mixes of policy options to fight the complex challenges of the current health workforce, we need to cross borders between policy domains as well. The recruitment and retention of health workers in the Netherlands is not only a responsibility of health policymakers, it is likewise a responsibility of the financial, social, labor, education, and legal policymakers, not only at the national level, but also on the regional, sectoral, and organizational level. And the challenge is to actually align these policy levels as well. And to close, while realizing that the limits to growth in healthcare are there and probably will not disappear. So that's
Ronald, thank you so much. Excellent. I would have so many questions to follow up, but I just focus on one thing. You know, Margaret, in her presentation, she was talking about the intersectoral governance mechanisms and the long-term relationships you need. And I think you have those both, you know, and can you say one or two words very briefly, you know, how you bring them together? What are the capacities needed? You know, what are the platforms you share with the other actors?
Well, we bring them together, as you say, and specifically, we as NIVEL support the Advisory Committee on Medical Manpower Planning, which is an independent organization advising the ministry, not only the Ministry of Health, but also the Ministry of Education on training inflow and other policy instruments. And we put those stakeholders, the Advisory Committee put those stakeholders simply together on the table. Given an influence also on the scenarios that are applied within the models, but also interpret and estimate what are the consequences of the outcomes of the model, what is feasible, what are feasible measures, and how to deal also with the uncertainties. So they are involved and they put together with a joint responsibility that stability and sustainability of the health workforce is a joint responsibility for them, given their different interests.
And I think one of the great achievements is actually that facts, figures, and methodologies are accepted across stakeholders. So you don't fight over these things.
That's the base, actually. That's the base for the discussion. That's right. Where
Ronald,
we are, and we can discuss about the future, but we should agree about the current state. Yes.
Thank you so much. Excellent. And now I would like to ask my colleague Chris to come on board and fill us in a little bit on the Georgian case. Chris, please, the floor is all yours.
Good morning. Thank you very much, Matthias. Thanks for inviting me. Thank you also to Margaret and to Ronald for a great introduction. and talk about the Netherlands. And I'm going to talk to you a little bit about Georgia. Georgia is an interesting country. I've been there several times. It's a very beautiful country. It's a country that used to be part of the Soviet Union, and like many countries in that area, there were significant changes post-1995. Essentially, in workforce planning and governance, what that meant was that there was a gradual abolishment and move away from a centralized planning and assignment system that existed in countries like Georgia during the period up to 1995. In 2004, the government of the day in Georgia undertook an extensive deregulation exercise, and gradually over years that manifested a number of problems. The governance between other ministries and the ministry responsible for health and stakeholders became very, very poor. In fact, almost non-existent. That led to a situation where the output of education, the doctors and nurses coming out of the system, was mismatched, and supply and demand were just not in harmony. It was a laissez-faire, unplanned approach to planning. And I think it's fair to say that it hasn't been successful. It led to significant skills mismatches across the workforce, demographic maldistribution, too many doctors, you might argue, and too few nurses and other allied health professionals working in the system, but also a very highly aged workforce with significant numbers, either within 10 years or actually working through retirement. Since 2012, however, the government has moved to take a much more objective approach to aiming towards universal health coverage and increased salaries of the health workforce. But between 2012 and 2019, perhaps, it was still characterized by low levels of system governance and still highly driven by private sector input. From about 2019, the government has started to take clear steps forward. But we do find the current challenges that exist are poor workforce governance, and that's the planning system between the ministries, between stakeholders being involved in decision making. And in fact, the ministry does very little planning. There is very little HRH planning capacity at the ministry. And we find that the investment in the human resources within the ministry, i.e. those, if we take the 2006 World Health Report definition of a health worker being anybody involved in the delivery of health, the ministry workers are health workers, and they are low in relative numbers, and they are responsible for a wide range of policies, not just health. The Ministry of Internally Displaced People, Labour, Health and Social Affairs covers a wide amount of work, not just health. There's ineffective coordination of the health workforce supply still, and liaison with the educators is poor. And they've got particularly poor retention issues, particularly in the rural practices. So there are real challenges that the government face, but what they are doing is investing some significant resources. They recognise some of the challenges. So they are investing in a planning team, or they're about to invest in a planning team, should I say. And they are investing in the workforce, both in producing and training the workforce, especially in primary healthcare, and looking to take advantage of the digital technologies that may enhance both the delivery of care, improve the patient outcomes, but also equip rural practices with much more access to improve services that they can deliver to their patients, and linking in with other providers. And they're also looking at reviewing the nature of primary healthcare. They've just launched a report around looking at networking primary healthcare providers to improve their skill distribution, to improve their workforce retention, and to improve the training and development. They are developing a primary healthcare HRH reporting system, which will give better data. And they're also looking to improve regulation and improve recruitment and retention. And what we see in the Georgian example is that it's very difficult for a system to operate healthcare effectively if it doesn't have control over the governance of the HRH supply side. And what we found from 2004, well, indeed from 1995 through to 2019, was that level of deregulation, that level of laissez-faire approach to workforce planning resulted in significant mismatches between the supply and demand, and indeed the skills required. So on multiple levels, if you look at how the labour market framework operates, the policies between 1995 and 2012 to 2019 resulted in what you might describe as market failure of the workforce supply. So Matthias, I think what it is to be said then is that the Georgian government, having recognised this, is now starting to invest significant time and effort in the workforce supply, understanding what that looks like and working across the system. There is still a way to go, but they are making moves within the current construct to be able to do that.
Thanks, Chris. Many important messages coming from your side. First of all, if you once have ruined your planning and forecasting system, it's very difficult and costly to re-establish. Second is that you need to invest in the capacity, and it starts actually in the Ministry of Health. You need to have the staff qualified to understand the problem and then commission and include others. But one thing was really startling. It was very interesting. You said no control over the governance of the human resources for health side. That doesn't allow you to run the system. That doesn't allow you to introduce reforms if you don't have control over this part of the governance. So it's not something, an add-on or something we don't like to talk about. It's the most important, single most important lever for many health systems reforms to have a good grip on the governance. Thank you so much, Brett. Thank you so much, Chris. That was really great. And now it's my pleasure to ask Jim. Jim, we asked you to come on board as a discussion. You were running with Rania the 5th Global Forum on Human Resources for Health, and you've commissioned these policy briefs, actually, which we are still using for dissemination and talking to people. And you've been speaking at many conferences and occasions, and I guess you sometimes see this with new and fresh eyes. So please share your impressions, ideas, and messages. Floor is all yours.
Thank you very much, Matthias. Good morning, good afternoon to all participants, and thank you to Margaret, Ronald, and Chris. And I see we've got some early birds in Florida and Brazil joining us. So great that you've woken up early with your coffee to listen in today. 4 points, if I may, Matthias, having listened to some of our colleagues and their reflections. Firstly, to Margaret, to Joanna, to Michelle and Tara, a huge appreciation for putting the policy brief together with the European Observatory and bringing that material to the Global Forum. In addition to that, we also had a civil society action brief, which all the participants today do look at that, which took this evidence and said, what would civil society do around some of these best practices that Margaret highlighted? So a real appreciation to that. At the forum, number 2, we convened under the banner and the subtitle of Protect, Invest Together. And I think we're really seeing from the evidence base the emphasis on the together. This multi-sectoral undertaking, this partnership with all the related stakeholders that is absolutely essential to look at the data, to look at the information, have a dialogue and reach decisions accordingly that will drive progress on those needs. So it is a team sport, as Margaret emphasized, and we heard that message loud and clear in the forum. When on this particular topic, we had the Labour Minister from Niger, we had the Assistant Minister for Education in the Health Ministry in Brazil, we had the Health Minister from Romania, alongside private sector and a whole of government approach to socioeconomic development. So it is a team sport. Thirdly, the European Observatory renowned themselves for helping evidence-informed policy and practice. And that was the purpose of the partnership with the Observatory and with Margaret and the co-authors on this topic, is to put the evidence into the public domain that takes our work further forward. That evidence leads to policy decisions, that leads to governance decisions. We've already seen the governance in the World Health Assembly taking on board this intersectoral approach as articulated through the resolution last year on the Working for Health action plan, which really looks at the same issues that we're discussing here, bringing all sectors together, coming further forward to do that. And the co-benefits of this are evident, and Margaret emphasized in the brief and in her remarks, the co-benefits in creating jobs for women and youth in a socioeconomic human capital development coming through. Finally, the fourth point, Matthias, just reflecting on the remarks earlier, change and action is what we're trying to drive. And we had the forum in Geneva during the 75th birthday week of the World Health Organization. It's been around a long time, and hopefully it will continue to promote health for all and achieve that purpose in the future. But as we look at 75 years of history of WHO, how do we learn for the next 7.5 years of the Sustainable Development Goals, and what actions will we take? And one of those actions, it's just to colleagues here that are listening in, that are test yourself first of all. What is your knowledge of some of the intersectoral partnerships that are necessary? One approach we used occasionally within WHO is to ask colleagues, who is the head of the health portfolio in the World Bank? Most people will give you a correct answer, but then test them. Who's the head of the education portfolio? Who is the head of the gender portfolio? Who is the head, the director of the jobs portfolio? Because if you're not reading and listening and looking at what are being published around those sectors, we ourselves as health actors are not driving and taking responsibility for an intersectoral agenda further forward. But again, thank you, Matthias, back to you.
Jim, thank you so much for sharing your thoughtful consideration. And there are so many points I could follow up alone. The metaphor, it's team sport. I totally agree, but at the same time, you need to make decisions who is actually on the team and in what role. We've seen that in the past in many countries in Europe that, for example, the doctors were driving the health workforce agenda, and not always into the direction we would like to see health systems go. The co-benefits, that's absolutely essential, because I think that we need to be much clearer that investment in the health workforce is also investment in decent health, in pay and gender equality, and in many other things which are very important for the sustainable development goals and the well-being economy. And last but not least, I would like to congratulate you, because you say this is all directed towards change, but I felt that this year's Global Forum was very much political, actually, and a lot of decision makers were there to discuss their particular options. So thank you so much, Jim. And now I would like to invite all the speakers to switch on their videos. And Erica, it's your moment. Please fill us in what's coming through the chat box.
Very busy chat box. Absolutely fantastic engagement. Thank you, everybody. But here are just a handful of questions. Hopefully we'll get another round in. But one of the questions is, can somebody outline what WHO has been doing to support intersectoral cooperation for the health workforce? So that's probably one for Jim. A nice one for you. But quite a lot of people saying, collaboration is a great idea, but what are your tips on how you can really achieve it? And balance and negotiate power dynamics and different perspectives. So the top tips for making that happen. And one of the co-authors also pointed out the role of the private sector healthcare providers. Your top tips are getting data out of them to support planning, but also how can we include private sector providers in these intersectoral working. And yeah, then hopefully we'll come back for another round. Thank you.
Yes, Margaret, shall we start with you?
I think the one around top tips, lots of top tips, obviously. One that we focus on here are those intersectoral mechanisms, making sure voices are heard. We heard last week particularly about health workers' voices, making sure they're there. They are represented through, you know, associations and councils and so on, but listening to what they have to say to understand what are some of the issues. But those mechanisms, as you said, Matthias, as well, it's a team sport, but who decides who's on the team is really important. The transparency of the processes. I think those mechanisms supporting those, ensuring that we have people at the table and, you know, continuously, that there is also literacy, the health workforce literacy, and understanding of the health workforce issues, which can only come through the evidence and the data that we provide. I'll stop there.
Yeah, thank you so much. I think that's very important that all the stakeholders get heard. And some of them have difficulties because, you know, if you think about some professional association which are dominated by the elderly members, but not by the young ones who are the future we want to build on. So it's also very important to see how we can connect to them, maybe through polls or specific meetings and stuff like this. Thank you so much, Margaret. Ronald, would you like to come as the next, probably the tips as well?
Sure. Well, I fully agree that also the professional associations play a key role. That's also the case in the Netherlands. And at the beginning of our system, they were actually the only player in of the team, you know, and that has been changed. And what I would like to stress again, it's a joint responsibility, not only of the professional associations, but also of the training institutes, of the ministry, and with regard to the budgets, the health insurers are in the driving seat in the Dutch healthcare system. So you need to have them on board, and the patients associations as well, because the joint responsibility and the joint stake and interest is to have stability on the labor market. Nobody wants shortages, nobody wants stress, burnout, etc. So that's the common goal, to fight this. And there are different directions and the different solutions. And that's what the discussion needs to be about. But also, you need to agree on what is the current state and what are the trends that are developing, and jointly discuss this policy mix that is most appropriate. And also try to tailor this with regard to different sectors and with regard to different occupations, because there are huge differences between them. And we often try to aim for an integral health workforce policy for all health workforces, but we need to recognize the variety and the differences that are exist between the occupations and the educations.
Thank you so much. So clear message, you need to grow actually your stakeholder participation and your platforms and the involvement.
On the long term as well, that's right. Yes.
Yes. Okay, thank you so much. Chris, please.
Yeah, that's a really fascinating question, and I agree with both Margaret and Ronald. One of the things I would add to both comments is actually there has to be clarity. Clarity of what it is the policy you're trying to meet is. So what is the government of the day saying its strategy for delivering healthcare looks like, and what does that mean for the workforce? And that's about what Ronald was talking about the long term, understanding the long term, but also recognizing that it takes a long time to grow a health workforce. And so you have to think about how you ameliorate the skills and the services that the existing workforce can do, how you think about how you upskill those or change the skills or adapt the skills, looking at the shape of the workforce. And I think that requires that you have an open and honest conversation. Your stakeholders have to include your staff side, your employee side, the payees. You have to be very clear about the scope of what it is you're trying to do. And therefore, you need open and clear data and information that allows all participants around the table to do it. And the key piece here is there's honesty. If you want to have an open and honest conversation around it and a dialogue, you need to be able to share information, and people have to be able to believe that what they are participating in is an objective and honest process. There was a point about the private sector in there that I think we probably need to pick up on. Getting data from the private sector in many countries is really difficult. And actually, there is no easy way to get data from the private sector if they're not willing to participate. So some of the things you need to think about are, how do you get the private sector to buy into the planning conundrum? And I think some of that might be working along what is in their best interests. Their best interest is served by having an available workforce that meets their demands as well as that of the public provision. And failing to provide information actually could lead to scarcity and drive up their prices, their costs in terms of delivering healthcare. And at the end of the day, they want to be competitive. So I suspect, working on their best interests and what it is they want out of the system might be a way of getting them to contribute more. But let's not be idealistic about it. They're never going to contribute perhaps as much as you want from the public sector, and you have to work with them to get as much information as you possibly can.
Chris, again, so many things I could pick up, but just let me emphasize one of the things you were talking about. You were saying that curricular development and then the training takes quite a long time, and there's need for reskilling and upskilling in between, actually. And this is also something which needs to be agreed on, intersectorality. And last week, we had actually the discussion on the flexible regulation, allowing health professionals to expand the scope of their tasks, that they can do, for example, more prescriptive activities than before. And this would be part of the reskilling and upskilling, actually. And therefore, you need also the intersectorality. Think about the conflicts in some countries just between general practitioners and pharmacists, about looking after people with multimorbidities or vaccine people. Thank you so much, Chris. And now, Jim, please.
Thanks, Brandy. I think I'll pick up the question on what is WHO doing. And I'm going to stay on the theme of evidence-informed policy and practice. So evidence, the key element the WHO does, bringing the evidence together. We've seen the work of the High-Level Commission on Health, Employment and Economic Growth, the work on the gendered nature of the workforce, the co-benefits, the Global Health and Care Worker Compact, et cetera, et cetera. So bringing that evidence to bear, using that to inform policy. And those policies adopted in the World Health Assembly, the Working for Health Action Plan, the education emphasis around nursing and midwifery, the resolutions and decisions on the health system's needs to strengthen community health workforces, the work on public health. So these decisions, these governance decisions from the evidence base in the Assembly, but then into practice. And that's where we need to go the next mile. The second half of the SDGs is to drive that action in every country to be able to take some of this evidence and policy, global governance policy decisions into practice. And you heard the Director General, Dr. Tedros, makes several commitments in his closing remarks at the 5th Global Forum. Workforce and this intersectorality around education and jobs for women and youth will be a priority in the next 5 years of WHO's operations. He will increase the resources to this domain of work to support countries to take action. He will convene a multi-sectoral advisory group of experts, not just from health, but outside the health. Maybe some of those people from the World Bank responsible for gender, education and jobs to come and advise him as Director General on what actions we'd need to take. And what are we doing? We invite you all to join us together and partner with us on this evidence policy practice journey. Thank you.
Thank you so much. And that's really great news that the efforts made have been seen, actually, and that there will be more investment on the side of WHO. And actually, I find it already stunning that WHO, with its limited resources and limited stuff, is making so much noise, actually, and having impact both at global, regional, but also national level, and is providing a lot of guidance. I think, Erica, we don't have time for another round, and I would like to hand over for Margaret just for a couple of closing comments and wrapping up together with you. Please, Margaret.
Thanks, Matthias. Just to repeat those key messages, those key practices that need to be taken on board by the health sector, by Ministry of Health. We talked about political leadership and political commitment. We mentioned how that needs to be sustained. It's not a one-off process. It needs to be sustained and invested in. But we also need to have a Ministry of Health that has the capacity, both the soft and the hard skills of negotiating, bringing partners together, to be able to mobilize investment, mobilize support for these intersectoral collaboration mechanisms and the action that is achieved through them. I think the other point is around data. We heard about data from across the health and care workforce, including the private sector, ensuring that we have a very good understanding and be able to communicate that to people. Thanks.
Margaret, thank you so much for these closing remarks. And just a little bit of a hint. Next week, we will have another webinar in this Human Resources for Health series. And it's about where do we find the money for smart investment in the health and care workforce. And I think it will be very exciting as again, we have asked Barbara Pake from Australia to give us a keynote, and Jim will be with us again. And I can only ask you, watch our event site, connect, stay tuned, put in your question in our chat box and get involved in the discussion. So thank you so much and bye-bye.